Good evening, everybody. Welcome to Carolina Orthopedics. I'm going to talk about why do my hands hurt. A quick introduction. My name's Andy Putman. I'm originally from Atlanta, Georgia. I joined the practice about 2 years ago. I did my undergrad at Auburn University, and then I married a Georgia Bulldog, came back to Atlanta, did my residency there in orthopedics, and then got out of Atlanta. The traffic, as you know, is fairly bad. So we went to Indianapolis next. I did a hand surgery fellowship at the Indiana Hand to Shoulder Center, which I'm proud to say really one of the preeminent hand centers in the world. Enjoyed our time there. We did pick up 3 children along the way, and then moved here. So a little bit about tonight's talk. We're going to cover really the most common things that I see on a daily basis that make our hands hurt. Obviously, there's a lot of other possible causes to make our hands hurt, but these are by far the most common things I see. So hand arthritis. See this all day, every day. It's really wear and tear on the hands and obviously affects many joints in the body. It's when the joint begins to deteriorate over time. Our joints wear out. They lose cartilage, which is that shiny surface over the joints. As you lose that surface, then the bones begin to rub, and that's painful, and that hurts. Some of the common causes for arthritis are your routine osteoarthritis, as well as rheumatoid arthritis, or there may have been a previous injury or trauma to that area and led to breakdown of that joint as well. So really with arthritis, it typically feels like dull, achy pain. It comes along gradually. Now sometimes it can really flare up acutely. So if you happen to do something in particular or do too much yard work, the next day you may really feel it, and that can be a very common problem with arthritis. It's often associated when we do periods of heavy activity. That will make it worse, obviously. And then a lot of people talk about being stiff and painful in the morning, and that's a common indicator of arthritis. So a little on the anatomy of the hand. The CMC joint at the base of the thumb, we'll cover all these. That's probably the most common spot I see for arthritis. And then we'll go through what's called the MP joints, which is the big knuckle on the finger. And as you come down, the PIP joint, and then the DIP joint at the end. And we'll cover all those. So basilar thumb arthritis, pain at the base of the thumb, again, the most common I see. Women age 45 to 65 are the ones that really get this the most routinely. People will talk about pain with opening jars, opening doorknobs, trying to really grip or grasp things. And again, it's an achy, radiating type pain, as the picture shows right at the base of the thumb, but it can cause a circle of pain around that area. So people will even say, hey, it's radiating up my arm, but that's the source a lot of times. So treatment. There are literally hundreds of braces out there that can be effective for basilar thumb arthritis. A couple of the common ones that are shown here. You have your smaller one up at the top, and those are great because they're a little easier to wear. And then at the bottom you have a thumb spica, which is larger and more supportive, but obviously a little more obtrusive as far as wear and daily life. Anti-inflammatories can be very helpful. Your Advil, Aleve, Motrin, or there's some creams that you can rub on your hand as well that can really help this situation. Simple heat and ice, and mixing those back and forth. Those can make things feel a lot better. And a lot of this applies to any joint in the body, obviously. And then a cortisone injection for thumb arthritis can really do a world of good. I know everybody's afraid of needles, but cortisone is really helpful in this situation. And then if those things aren't working, then obviously the fallback is going to be an operation. The classic operation for basilar thumb arthritis was invented approximately 50 years ago. The common term for it is a CMC arthroplasty. There's a small bone here circled in red called the trapezium, which we simply remove. That bone's involved in the arthritis. That's removed, and then from there, there's several variations, but many hand surgeons will use a tendon from your wrist or your forearm, and they use that, 1, to stabilize the thumb, and 2, to act as a rubber spacer to cushion the new thumb. And it's been very effective for a very long time and is really the traditional operation in this situation. There are some alternative options, and part of my job is to try to guide you and pick which option is best for you. Fusion, a lot of times that will be appropriate for a younger patient in their 20s and 30s. There are some prosthetic replacements, some that are made of rubber or silicone, some that are made of metal. Those are a little bit more questionable track record, but they can be appropriate in the right situation. And then more recently, arthroscopy, or putting cameras into the joint and cleaning things out, has become more popular as well. So finger arthritis, a little bit about the MCP joint and the PIP joints, which can be treated in a fairly similar fashion. Again, heat and ice, and really for the fingers, simply soaking them in warm water can really be helpful, especially in the morning when they're achy and stiff, to get them going. Your anti-inflammatories again, and then cortisone injections can be helpful. These joints are fairly small, so from a technical standpoint, it can be somewhat more difficult to get those injections in. But if we can get them in there, they can do a world of good. And then surgery. As far as surgery for the MCP and the PIP joints, which is the larger knuckles, we can actually replace these knuckles, and those have been doing well. There's a silicone implant, and then more recently a metal implant made of pyrocarbon that do very well. And then joint fusion sometimes is a more appropriate surgery as well. And again, that's a good discussion between the physician and the patient about what option is best for you. The DIP joint, which is the knuckle at the end of the finger, is treated a little bit differently. So very commonly, people will develop mucus cyst at the DIP joint. It's a small fluid-filled sac at the end. A lot of folks will have these hard nodules over the tips of the fingers as well, so they're a little bit different. But the mucus cysts are very common. It really indicates that there's underlying arthritis. Sometimes it can lead to a nail deformity, so the cyst itself can be pressing on the nail, and the nail will begin to change shape or get a little ridge in the nail, and that can be an issue. Or it can actually leak fluid or even become infected, and obviously that presents an issue as well. So our treatment for mucus cyst, it really and truly, if it's not bothering you, you can leave it alone. If it's not leaking, it's not getting infected, it's just there, you can just observe it and just keep an eye on it, and we don't necessarily need to do anything for it. However, if it does begin to leak or become infected, if it's starting to press on the nail, then we generally recommend surgery at that point. The surgery is fairly simple, just takes several minutes, and we simply cut the cyst out, and that generally does very well. So with DIP joint arthritis, if it's more severe, you'll get these hard nodules, such as in this picture, and that's a different situation. Again, if it's not bothering you, you can simply observe and treat it conservatively, things like heat, ice, anti-inflammatories. But if it's really significantly giving you a lot of pain and bothering you, then we consider surgery at that point. Our surgery options, really the most reliable option here is going to fuse the finger. This is a picture, and certainly it sounds worse than it is, but there's a little screw that you can put in, and that will keep the joint still, and that way the bones don't rub on each other, and takes away that pain. So another common condition, switching gears to trigger fingers. I'd be willing to bet that there's several people in here that have one. They're extremely common. It can be any finger, or the thumb is very common as well. That's described by a painful clicking finger. A lot of folks will talk about, especially in the morning, their finger will be sitting down and they almost have to pop it back out to get it to open, and that can be very painful, and oftentimes worse in the morning. So women, unfortunately, get it more than men. The target audience is 45 to 65, but it really shows up, anytime, anywhere. Folks with diabetes, folks that are pregnant or have thyroid conditions are certainly going to be more prone to have this, and we do take that into consideration as to how we treat that as well. A little bit about the anatomy. The tendon that bends a finger, as you get into the base of the finger, enters a sheath or a tunnel. And that can present some issues if the tendon becomes swollen or if the tunnel itself becomes inflamed. The tendon will begin to grind and click as it tries to pass through that sheath, and that's painful, and then it can even begin to lock and catch. So treatment, cortisone injections can be incredibly effective for this. There's variable rates of cure. The first injection, though, is oftentimes all it takes. And then if that injection helps but doesn't take it away entirely, we can try a second injection, and a lot of times that will take away the issue. Studies have shown that the third injection, however, generally doesn't help. So if we've tried 2 injections and the trigger finger is still around, that's when we really move strongly to surgery. Or there are times when we go ahead and skip those injections and we say, hey, you would do better just going straight to an operation. So the operation itself, again, is fairly straightforward. It just takes several minutes. And there's several ways to do it, but the core idea is to open that sheath or open that tunnel, and that way the tendon can slide smoothly and takes away that trigger finger, and a very high rate of success and a fairly quick recovery. So along those same lines as tendinitis, it's a similar condition. It can show up in multiple spots in the hand or wrist. That comes along with pain with activity, repetitive motion, overuse, those types of things will lead to those tendons becoming inflamed. The typical things we can do are just simply rest. Overactivity causes this, so slowing it down for a brief period can oftentimes take away that tendinitis. Wearing a brace to support the hand or wrist, your anti-inflammatories again. The most common form of tendinitis that I see is Dequervain's tendinitis. That's right along the thumb side of the wrist, and again comes along with repetitive use. Some common groups that get it, young mothers get it because of how they're having to hold the babies, oftentimes lead to Dequervain's tendinitis. And then women, middle-aged women are very prone to this as well. It's a very fixable issue. The symptoms that come along this, pain with use of the thumb, anytime you're trying to grasp or hold an object. A lot of times people will get significant swelling along that side of the wrist. And they can even develop a little popping or clicking or a small firm cyst that almost feels like a little BB, and that can develop as well. The common test that's famous in the medical world is Finkelstein's test. So if you take your thumb, put it into your palm there, and then simply move your wrist up and down. As you come down, that stretches that tendon. It can recreate the pain. We can use that to diagnose that condition. So some treatment options for this, again, kind of a broken record, but rest, anti-inflammatories. The most popular way to get this to go away is a combination of wearing a thumb spica brace, pictured on top here, and then a cortisone injection. And that combination has been proven to be very successful. And really, a lot of times we can avoid surgery with those two things. The surgery itself, a simple opening up that tunnel, very similar to a trigger finger. Once that tunnel is opened, again, the tendon has more room to slide back and forth. It won't click and grind, and that is typically a very successful operation. And so our last topic, but will be a fairly big topic, is numbness in the hands. We get that a lot, and there can be a lot of reasons for that. And we'll go through those. Multiple causes. The underlying issue is that nerves are being damaged or being pinched or simply not healthy. It may start as just occasional symptoms and then gradually worsen to where it's constant and really can be worrisome to both the patient and the physician. A severe bout of numbness or nerve damage can actually lead to weakness or paralysis in the hands. And so it can be a fairly concerning condition for us. So our job as doctors is to try to figure out where the nerve is getting pinched or what the issue is. That can be a difficult job. The nerves obviously start in the brain, come down the spine, and we need to figure out where they're getting pinched. And then once we've determined that, then we can guide you in deciding what your best treatment option is. An early diagnosis is very helpful. If we catch it sooner, then some of our non-operative treatments really work better. So it's very, very helpful for both of us to try to catch that as soon as possible. And then also we can make sure that we prevent any irreversible damage and make sure that none of the more significant things like weakness, paralysis develop. So some symptoms if you walk into my office that I'm going to ask you about, a list of questions. Which fingers are most affected? That can be very helpful to us. One or both hands. Are both hands going numb, or is it just one hand? Are you having any numbness in the feet as well? Is there any pain in the neck, or is any pain shooting down from your neck? That can guide us. Try to pay close attention to what activities or what things you're doing make the hands go numb. And so that can give us a sense of what the problem might be. And then many times people will describe numbness during the night, and that's helpful as well. So again, the anatomy, the nerves start, brain and spine, leave there, go down the arm into the extremities. They enter into, as far as the arm, the brachial plexus, and that is a significant bundle of nerves, and then as it gets into the arm, it splits into three major nerves, many more, but three major nerves that are important to us: the median nerve, ulnar nerve, and radial nerve. And so what causes that numbness and tingling? The compression on the nerve or a nerve injury. And I'm going to take a quick detour because I'm a hand surgeon dealing with the hand and the upper extremity. But really it's important to know that sometimes those nerves are getting pinched in the neck. And that's one of the things that is my job to sort that out as well. If it's getting pinched in the neck, then ultimately we'll probably wind up in a spine doctor's office. And that's important to kind of guide you to what physician to see. And then diabetes is a common reason for numbness. So the neuropathy from diabetes can often lead to what we call a glove stocking distribution. So your hands and your feet are numb, and that's a common issue as well. And there's many other issues, but I'm going to focus again on what my specialty is and the hand and upper extremity. So the nerves as they come into the arm, and we'll go through these, especially the median and ulnar nerve can really be a big factor in numbness. With the hand, as these nerves get into the hand, they go to specific areas. And so that's what I touch on when I ask, what fingers are going numb. That can guide us as to what nerve is the problem. So the median nerve, really one of the most common nerves to have compression, winds up going to the thumb, index, middle, and then half of the ring finger. And the most common spot for this to get pinched or compressed is at the carpal tunnel. So there's a ligament shown here called the transverse carpal ligament that lays across the base of the palm. And then as the nerve gets into the palm, that ligament will begin to press on the nerve, or that tunnel that it travels in, called the carpal tunnel, becomes inflamed, and then the nerve is not happy, quite frankly. And so that can lead to carpal tunnel syndrome, which is obviously a very common condition I'm sure everyone has heard mention of at some point. So women get carpal tunnel syndrome more than men. There's multiple reasons to get it, but the most common reason is just what we call idiopathic. It really, no rhyme or reason, just develops. There's some controversy about whether it's related to overuse, repetitive activities, and so forth. Certainly people that are on the computer, typing, doing those types of things, do seem to be more prone to carpal tunnel. And there's a lot of thoughts on that one way or the other. Pregnancy, diabetes, rheumatoid arthritis, thyroid conditions, kidney conditions can make you more prone to carpal tunnel as well. So some common symptoms are really the most common complaint that you'll see is people talk about night pain. So you wake up at night, your hands feel numb, tingly, people try to shake them out to try to get that numbness to go away. You also have numbness while you're talking on a cell phone, while you're driving a car with the hands on the steering wheel, working on the computer, those types of things. These symptoms develop. So there's some common tests that we do. Really putting pressure directly on the nerve with your thumb. That can lead to or recreate some numbness. Holding your hands in an awkward position, but either like this or like that. Either way for approximately 30 to 60 seconds can begin to recreate that numbness, and that gives us a sign that you possibly have carpal tunnel syndrome. Anytime the wrist is bent, that is going to kink the nerve and cause some pressure on the nerve. So that's the basis of that test. We also test your sensation. We want to make sure that the nerves are still able to feel appropriately. Not a common sight, but sometimes what develops with carpal tunnel syndrome is people will begin to lose the musculature at the base of the thumb. And that's very important to know, because that indicates a very severe case of carpal tunnel syndrome. And we certainly get worried if we begin to see that sign. And then we can also use a battery of tests, including an EMG and a nerve conduction study. That's usually further along the road as we get into to try and diagnose carpal tunnel syndrome. But we can take the information from those tests and really help us to make sure we're on the right path. So some common treatment options: simply wearing a wrist brace at night. We all sleep with our wrist bent, and so that's the fetal position. With our wrist bent like that, again, it kinks the nerve. So a simple wrist brace can act to keep the wrist straight, and that can take the pressure off the nerve. And then wearing that during the day, if you're able to, that can help as well. Also pay attention to what you're doing that causes the nerves or causes the hands to feel numb. So working on the computer is a real common complaint. So try to make sure that ergonomically you're set up. There's some different keyboards, different mouse, different ways to position yourself in the chair, and those can be helpful. And try to pay attention again to what other things you might can do to make those symptoms go away. Medications, anti-inflammatories can help to a certain degree, but not a lot of studies out there saying that this makes a tremendous difference. A short course of prednisone, as with a steroid, an oral steroid, that can make a difference for a temporary period, and sometimes enough to keep it away for a while. I come back to this pretty frequently, but cortisone injections can be very helpful for carpal tunnel syndrome. They act to decrease the inflammation in the carpal tunnel and then decrease the inflammation around the nerve, and can be very effective in taking away those symptoms. So when to consider surgery: severe cases, we can help you determine when that's there, but certainly losing the muscle in the thumb. There's some findings on the nerve test, the EMG, that can indicate a severe case. If you're having constant numbness and it just doesn't go away ever, that's sometimes an indication to move forward with an operation. If our non-operative treatments are not working, so our injections, our braces, we're trying our best, but these things aren't successful, then we move forward with an operation. And certainly the goal here is to prevent any irreversible damage in the nerve. So carpal tunnel release itself is one of the more common procedures we do. It is an outpatient surgery. It takes several minutes. You can either do it under local anesthesia, where we just numb the area up, or we can do it under light sedation. We're similar to a colonoscopy, where you're just kind of lightly asleep. And it's a fairly routine procedure. The goal here is to open up that carpal tunnel, so the transverse carpal ligament that lays across the palm. We simply go down and open that ligament up, and then the nerve has more room, and that allows that numbness to recede. Typically does very well. It's been done for many years and has an excellent track record. There's multiple ways to do it, but they're all getting at the same goal, is to create space for that nerve by opening up that ligament. The recovery is pretty straightforward. The sutures are removed at 2 weeks. The hand is typically sore for a couple of weeks. We ask that you limit your lifting for 3 to 4 weeks. The strength in the hand takes between 6 and 12 weeks to fully recover, but generally speaking, the hand is able to do many things right away and then just take some time to get back into your heavy activity. And really, depending on your job or your daily life, you can return to those activities, or golf is what a lot of people ask me about. You can return to those things as soon as you feel comfortable. So a different nerve that we'll cover is the ulnar nerve. That's the funny bone nerve right around the inside of your elbow. That comes down to the ring and the pinky finger. So numbness in those fingers, we become alert to possibly an ulnar nerve lesion. So that can lead to weakness and clumsiness in the hands. The ulnar nerve controls a significant amount of muscles in the hand. So very important if you're having trouble getting your buttons on, things of that nature, along with numbness in the ring and the pinky finger, is something to be mindful of. This brings on nighttime symptoms similar to a carpal tunnel, but again, generally focuses on the ring and the small finger. So one of the signs of atrophy or loss of muscle we'll see here is right on the inside of the index finger. So if you notice a difference from one hand to the other, then that can sometimes indicate that the ulnar nerve is having some issues and you're beginning to lose that muscle. We also can see clawing, so the ring and the small finger will begin to pull down if the ulnar nerve is significantly damaged. So the ulnar nerve itself, there's multiple spots that it can be getting pinched, but by far the inside of the elbow, called the cubital tunnel, is the most common spot for the ulnar nerve to get pinched. We also see it pinched less commonly in the wrist. That's typically with folks riding motorcycles or bicycles, and then some situations where you're doing heavy labor, such as a jackhammer and things of that nature. But I'll focus on cubital tunnel syndrome. Again, very common. We all sleep with our elbows bent, coming back to the fetal position. So as that elbow is bent, the ulnar nerve gets pinched right on the inside of the elbow. We also notice it if we're talking on a cell phone, again, hands on the steering wheel. But the difference between that and carpal tunnel syndrome will be, the numbness in the ring and the small finger. So our non-operative treatments, the main goal here is to try to keep the elbow straight as much as possible. There's different ways to do that. There are some braces out there that you can wear at night. They're not always the most comfortable, but trying to keep that arm straight at night can take the pressure off the nerve. You can also try to wear an elbow pad during the day. So if we set our elbow down on something just wrong, then that can cause some compression and some irritation on that nerve as well. And then a very cheap but effective option is to simply take some towels at night, put them in the crook of your elbow, and then take an ACE wrap or some tape, wrap that around your arm, and then that will prevent your elbow from bending up, and that can be effective as well. And then we can also have a therapist make a splint, and that splint's designed to keep your arm in a comfortable position that can take the pressure off the nerve as well. So those are the non-operative treatments for cubital tunnel. Cortisone injections are typically not tried for that. If those things aren't working, or the symptoms are severe, you're beginning to lose muscle in your hand, your nerve test is concerning, then we move forward with the operation. There are several different ways to do this and several techniques out there. The incision itself typically is fairly small, but it really depends on certain situations. And by that I mean sometimes the ulnar nerve actually wants to sit around to the front of the elbow. So anatomically it sits in the back of the elbow, but sometimes it will actually want to click and snap to the front of the elbow. And if that's the case, and we see that, then we go ahead and do what's called a transposition. So we'll make a little pocket for the nerve to sit in. That, one, makes our surgery a little more involved, and then two, requires some splinting afterwards, and changes the length of our incision and what all is involved as far as the recovery. But after you have it, you do come out looking like this gentleman, so it's all good. And so if it's simply a cubital tunnel release, we can typically just do some soft dressings and bandages. If we have to do the transposition and move the nerve to the front of the elbow, then that will require a period of splinting. So numbness and tingling, there are multiple reasons, a good quality exam, and then really the patients are their best advocates. If you guys are able to tell us what fingers are going numb and what's making it go numb, that often is all we need to make a diagnosis. And focus on starting with non-operative treatment, your braces, rest, avoiding the activities that make it go numb, injections, and again, the overall idea that in a severe case, we need to move forward with an operation, or if the non-operative treatments are not successful, then that's another reason to move forward with an operation. So just in closing, our hands are really incredible parts of us and are very complex. They are finely tuned instruments, so sometimes any little thing can really affect your hands. So pay close attention to what things are making it hurt and what things make it numb. That can help us. A good quality exam, we can decide what's going on. And then a lot of simple non-operative measures. Your heat, ice, anti-inflammatories, injections, braces can all make a world of difference. And then certainly if those things aren't working, then we can move forward with surgery as well. And that concludes my talk. I'd be glad to take any questions and hope that was helpful. All right.